Well, hello everybody, and welcome to Chapter 14, which is Treatment of Psychological Disorders. So in terms of an introduction to treatment, there's a long history of treatment of psychological disorders, and you could take a history of psychology class and get a lot more detail here. But long ago in the Stone Age, people believed that psychological disorders were caused by possession, demons or evil spirits that inhabited the person. And so the treatment, and we found many skulls with these holes in them, and the treatment was called trephination, which is drilling of holes in the skulls to create an exit route so that evil spirit can fly out. Not exactly a treatment that actually worked, but this was the way they thought about it back then. In the 16th century, asylums became more of a treatment for people with psychiatric diagnoses, and religious groups began creating these asylums or special places to treat and house people with psychological disorders. Now remember, we didn't have really good medications. So for someone diagnosed with, let's say, schizophrenia, who was having hallucinations and delusions, there really wasn't any good, effective treatment at that time. And so despite good intentions, the asylums really were very overcrowded. They resembled prisons. And again, it really wasn't a treatment, or the treatments they were using were not really working. And so it was a place to house people with significant psychiatric and psychological disorders. In the late 1970s, a reform movement was brought about that advocated for more moral treatment, more kindness, more respect for individuals in the asylums. And then in the early 1990s, psychiatrists began to view mental health as a continuum, and we started to classify mental disorders. And then in 1952, we had the first DSM. And then since then, our treatment has really improved. We certainly have a ways to go, but there are very many good medications now, psychotherapy, etc. So we have really improved the treatment. And so in the 1950s and 60s, and the United States experienced what we call deinstitutionalization, or mass movement of patients out with psychological disorders out of institutions with the attempt to reintegrate them into the community. So having people live at home, if possible, or live in some other kind of controlled setting aside from a psychiatric hospital or psychiatric asylum, as they were called, and have them do as much as they can, given the treatments we have now available. But despite deinstitutionalization, psychiatric hospitals and institutions continue to play an important role in psychological treatment. We certainly still have people who maybe for the first time have a severe episode of bipolar disorder or depression or schizophrenia. Those individuals are often hospitalized. They're given medications or some kind of treatment to stabilize them, and then as quickly as possible, they are released, right, and back to either their home or to the care of a family member, even perhaps to a group home where there's maybe a caregiver taking care of a few patients, but we're trying to move them out of psychiatric hospitals and limit the time there as much as possible. In terms of treatment, key terminology, we have biomedical therapies that rely on drugs or other medical procedures to improve psychological functioning, and then psychotherapy, where there's a trained professional, a therapist, that uses some kind of psychological techniques to help a person overcome their psychological difficulties and bring about personal growth. So in terms of theoretical perspectives, they play a big role in treatment. We've got insight-oriented therapies. These are psychotherapies that are aimed at increasing awareness of the self and the environment to help people gain insight into maybe why they're having the difficulties they're having, and how they can better understand themselves. And we also have behavioral therapies. These are therapies that focus really truly on behavioral change, using those learning principles of reinforcement, reward, to improve certain behaviors without really spending a lot of time having the person think about or talk about their feelings and why they may be having these feelings. At this point, most therapists use a combined approach, or an eclectic approach to therapy. Although there are some therapists who will say they are just purely behavioral therapists or purely humanistic therapists, many therapists use techniques from all of these different perspectives to best help in the particular situation that their patient finds themselves in. One of the keys for being a therapist is using evidence-based practice, which is choosing treatments that integrate the best available research findings. And this is why if you continue on in the field of psychology, you will have to take statistics class, you'll have to take a research methods class, because there is a lot of research done on treatments, and we need as therapists to be able to see what research is out there, what treatments are actually proven to be effective, and those are the ones that you would want to use, right? Instead of just thinking to yourself, I think this is the best way to treat depression, you would want to actually read other people's research on how other people have treated depression, research articles on different types of therapy, and then integrate and use the effective types of therapy in your therapy practice, in your clinical practice. Also, it's going to be very important, as we've talked about, to understand a patient's cultures, values, and preferences. So integrating all of this stuff together for an evidence-based practice in terms of therapy. There is a lot of difficulty in doing this type of research in terms of best outcomes, because it's not always easy to pinpoint what it means for as a success in terms of treating, let's say, depression or treating schizophrenia. Perhaps we're not able to get the person to have no hallucinations and no delusions, but is there some kind of a point where we feel, this is a success? How about with depression, right? Are we going to maybe alleviate the depression? Probably not forever. But what is going to be our success point? What are we going to call success? And so that becomes a research question that, again, you would discuss in a research class, how you define success in research. And it's also difficult for clinicians to remain free of bias. And it can be positive or negative when reporting successes and failures of clients. And this is not saying that researchers are trying to on purpose lie about their research or change the results, but we all have our innate biases, and sometimes that can kind of bleed into our research a little bit and our research findings. And so it's really important, and we have many techniques for doing so, to try to keep our research free of any bias. Things like double-blind studies, where you don't tell the researcher and the patient what group they're in. Are they getting a real medicine or a real treatment, or are they getting a placebo? Things like that. All right, let's talk about some insight-oriented therapies that, as we said, had a goal of developing some self-awareness or insight to help the person make improvement in their lives. And we're going to talk about a few here. Psychoanalysis, again, first, and mostly for the historic nature of it, was the first formal type of psychotherapy. And Freud proposed that humans are motivated by aggression and sex, and acting on these drives is not always compatible with what is okay to do in society. And so there is this conflict that's created by the drives that the person has, these aggressive sexual drives, and what is acceptable in society. And so those drives are repressed or put into the unconscious, so the person isn't aware of them. And it's these repressed behaviors that affect moods and behaviors, right? Making someone maybe depressed or anxious or aggressive in psychoanalytic theory. So a psychoanalyst would seek to bring these unresolved past conflicts and unacceptable influences from the unconscious into the conscious, where patients can deal with the problems more effectively. And so the goal of this type of psychotherapy is to release hidden unconscious thoughts and feelings in order to reduce their power in controlling that person's behavior. And they do this with a number of different techniques. This is the classic lay down on my couch in my office and talk to me. This is where that comes from. It was a psychoanalysis. And they do different things such as free association, where patients say aloud whatever comes to mind. Maybe the therapist says a word and then the patient says whatever word comes to mind right after that, a free association. And then the therapist tries to connect what words the person says to their unconscious in some way, looking for themes, again, of sexual themes or aggressive themes or themes of sadness, things like that. Dream interpretation, this is examining dreams for clues to the unconscious. So they often have people tell them about their dreams, and then again, they're looking for that hidden unconscious content of the dream. And transference is a key term in psychoanalysis, which is the transfer of feelings to a psychoanalyst from the patient of either love, they either start to really love their therapist, or anger, they're very angry at their therapist. And these are feelings that were originally directed at the patient's parents. Remember, psychoanalysis has a lot to do with childhood, or other authority figures. So whatever love they had or anger they had is often transferred to the therapist. So all of a sudden, the patient, like I said, is very angry at the therapist, or holds them in the highest regard and really loves them. That would be called transference. Psychoanalytic therapy can be very time-consuming, and because it's time-consuming, it can be expensive. People sometimes would go to a psychoanalyst maybe 3 times a week for an hour each, and that can get very expensive. It can also be difficult to determine its effectiveness because it's very individualized and quite subjective. But it may provide solutions to certain difficult issues. It gives people insight because they really are talking about themselves for hours each week. And it does provide treatment for some people. Some people really believe that this is, the best type of therapy and that it really has worked for them. Psychodynamic therapy is a type of insight therapy that incorporates a lot of the psychoanalytic themes, the importance of the unconscious conflicts and experiences from the past, but is shorter in duration and a little bit more direct. And we already said this. Sorry, it's there again. All in all, this type of therapy is just in general more time consuming. Not everybody would be up for spending hours a week with a therapist or could afford it. But again, some people find it extremely, extremely helpful, and will say that it really had given them great insight into whatever their issue was. Humanistic therapy, this is Carl Rogers and the humanistic movement. And this is the idea, as we've talked about, that human beings are inherently good. They're inclined towards growing, towards self-actualization, right, to being the best people they can be. People have basic biological demands for food and sex, but they also have powerful desires to, again, form close relationships, treat others with warmth and love, grow and mature, and just be the best person you could be. And so humanistic therapy is based on the idea that people have control of their behavior, they make choices about their lives, and they're really responsible for problem solving. This really emphasizes self-responsibility. The therapist can't fix the problem for you. You really have to fix the problem for yourself, and you have to come up with the solution that is best for you. And so they call this person-centered therapy or client-centered therapy, and the goal is to reach one's potential for self-actualization. And again, humans have this natural tendency toward growth or self-actualization or being able to achieve their full potential, and that there can be issues when there is an incongruence or a mismatch between who you really are, your real self, and your ideal self, who you want to be. And the main goal of treatment is to reduce this mismatch between the two selves, to help you go from your real self to your ideal self. Person-centered therapy is what we call non-directive. This is also kind of a very stereotypical therapist that you might see in a movie or TV show, where they just are listening. They say a lot of, I hear what you're saying. I understand what you're saying. A lot of that, right? The primary job of the therapist is to be empathic, to feel what the client is experiencing. This keyword of unconditional positive regard, that's a keyword for humanistic therapy. This means total acceptance of the client, okay? Unconditional positive regard. We regard our patients in this way, no matter what they say. Now, this is not to say that you are a cheerleader for them if they do bad things, if someone is very aggressive or violent, but you talk to them in a way that is positive, that you understand what they're saying, you understand what might have made them feel so angry, you're hearing them, and you're not treating them in a negative way. You're still feeling about them as a person in a positive way. Trying to be genuine, absolutely, authentic, and then being very active in your listening, picking up on the content to understand a position's point of view, and a lot of reflection. Things like, well, what I hear you saying is this. What I understand you to be feeling is this. So you reflect back, but you're not giving answers. The patient might come into you and say, I don't know how to deal with my husband. We have a very difficult relationship. I don't know what to do. You're not going to say, well, go home and these are the things you could do. You're going to say, I hear that. I hear this must be very hard. Tell me more about it. And the person talks more. And by letting them have this open, very positive, warm place to be able to say how they're feeling, the person will come up with their own solution to the problems. And that's the idea of person-centered therapy. All right, behavioral therapy. This is using the principles of classical conditioning, operant conditioning, observational learning, all of those learning techniques to replace maladaptive behaviors with those that are more adaptive. So again, this is not insight-oriented at all. In this case, we're not trying to say, why do you have social anxiety? Why are you afraid to go out into the world and be with other people? What we're saying is we want to change that behavior. It is maladaptive if you cannot go to the grocery store because you're afraid of being with people. So I'm going to either reinforce you for going to the grocery store or do something to just change the behavior. Some of the techniques we use are what's called exposure therapy. That's bringing a person into contact with whatever it is they're afraid of, with the goal of extinguishing or eliminating the fear response. So it could be, we're going to go to the grocery store today together. And here we go. We're just going to do it. Sometimes you even do exposure in the person's mind. You have them think about being in a grocery store, and then have them realize, okay, you're fine, etc. And the key is we also use response prevention, meaning encouraging someone to confront their fear and preventing him from responding the way one normally does. So if someone has a phobia of germs, let's say, well, you can make them go outside with some exposure therapy and put their hands in some dirt. Okay, that would cause them a lot of fear. And you would sit with them and say, okay, look, you're fine. You have dirt on your hands, but you're fine. And then you also have this response prevention, meaning you do not let them go wash their hands, because that's what they would want to do, right? They would typically go run, wash their hands with soap, sanitize their hands. That's what they want to do to alleviate the anxiety. But what you try to do in a behavioral experience and behavioral therapy is say, look, we're sitting here. You've had dirt on your hands now for 30 minutes and you're fine. And eventually that anxiety response decreases. Flooding is to confront the client with an anxiety-provoking stimulus that cannot be escaped. This causes a high degree of arousal. I think about this with myself. I've said I have an elevator phobia. If they just said, shoved me in an elevator and said, go ahead, there you go. Up you go to the top of the, Empire State Building. That would be flooding. I would have a lot of anxiety all at once. But we do find that when you do this kind of confrontation, again, it helps with anxiety. And oftentimes behavioral therapists will use an anxiety hierarchy where you have your patient list experiences ordered from least to most anxiety provoking, the idea of baby steps. So if a person is afraid of, let's say, going on an airplane, well, you might say, well, what's kind of the least provoking situation in terms of flying in an airplane? And they might say, well, when I know I have to go on a trip, that provides me some anxiety. Even if it's months away, I just know I have to do it and there's some anxiety. And then next in my hierarchy might be buying the plane tickets. And then next on my hierarchy might be packing for the trip. And the next high on the hierarchy of anxiety might be driving to the airport. And next would be sitting at the terminal. And the next would be getting on the airplane, right? And so you have these baby steps, and we'll talk about how we use that in that hierarchy list in some types of behavioral therapy, I think on the next slide. And we can even use virtual reality therapy. It works, absolutely. So you can have virtual reality exposure to whatever the person is afraid of, and we do find that that works as well. It doesn't have to be the real thing. Aversion therapy, this is again, behavioral approach. And you can see here in all of these therapy techniques, we're not asking the person, why are you afraid of going in an airplane? Why are you afraid of dirt on your hands? We don't care. In this therapy, all we want to do is change the behavior. Simple as that. Aversion therapy, another behavioral technique that uses classical conditioning to link problematic behaviors to an unpleasant physical reaction. And so one example of this is a medication called Antabuse that's used with alcoholics. Antabuse is a medication that interferes with the body's ability to break down alcohol. So when you combine this drug with even a small amount of alcohol, there's this immediate physical unpleasant reaction, vomiting, headache, etc. So if the person takes the medication and then drinks, they feel very sick. And again, this is the classical conditioning. Take the medication, drink the alcohol, feel sick. Eventually, all they have to do is drink the alcohol and they start to feel sick. That becomes the conditioned response. And so they are less likely to drink. The problem with this, or the difficulty, is that it's hard to get someone who is an alcoholic to take Antabuse before they go out drinking for the night, right? So it really often needs to be done with somebody if they have a roommate or a significant other or family member who is there giving them that medication so that this can work. Otherwise, it's hard to get people to voluntarily take that. Other types of behavior modification, behavioral therapy is behavioral modification, which is a therapeutic approach in which behaviors are shaped through reinforcement and punishment. One of the common types of behavior modification strategies is what we call a token economy. And this is a behavior strategy that uses tokens to reinforce desired behavior. We often use this with children or individuals with intellectual disabilities of some sort, in which the child starts with no tokens, and you could trade those tokens in for things that you want. So you could trade them in for maybe an ice cream cone or a movie ticket or something like that. When the child engages in whatever desirable behavior you're looking for, they're given a token, and eventually they can trade those tokens in for something that they want. I want to watch an hour of TV at night, or I want to play a video game or something like that. Again, we're not talking to the child about why they're not, acting in an appropriate way or anything like that. All we're trying to do is change the behavior. It's a purely behavioral technique, but it works. Now, another type of therapy would be cognitive behavioral therapy, or CBT. This has become more popular in recent years. This combines a cognitive and behavioral approach. So you're looking at changing the behaviors, but you are also paying attention to the thoughts, that they're both important in a cognitive behavioral approach. And one of the key types of therapies in a cognitive behavioral approach is something called systematic desensitization. And this is a treatment that combines that anxiety hierarchy that we talked about with relaxation techniques. And so what you often do is, again, here's our hierarchy for fear of needles. So you can see very least anxiety provoking, looking at a hypodermic needle, then looking at an actual needle, then touching the needle, then holding one, watching someone getting a shot, all the way up to getting a flu shot. And so what we try to do with systematic desensitization is have the person sitting quietly, comfortably in a chair. We teach them relaxation. And you can also Google this, particularly if you're feeling stressed. You can find different relaxation techniques, but we often do this, we call it progressive muscle relaxation, where you start at the top of your body and you try to tighten the muscles. In this case, they're saying tighten the muscles on your scalp as hard as you can. That's a hard one to do, for 10 seconds, and then relax. And then tighten the muscles on your face as hard as you can, and then relax. And then tighten the muscles in your shoulders for 10 seconds, and then relax. And so you start to learn the difference between, this is behavioral, between being tense and being relaxed. And with systematic desensitization, we often have the person sitting in our office, and we start at the bottom of the hierarchy fear. So imagine you're looking at a photo of a hypodermic needle. Just imagine that. Now they're getting tense, right? And we say, okay, now we're going to relax. Okay, we're going to go through that relaxation training. We're going to do that, tensing your scalp muscles, tensing your face muscles, all the way till your whole body is relaxed, even when you're thinking of looking at a photo of a hypodermic needle. And then once you can get through that least anxiety provoking part of the hierarchy, then we move up. Okay, now imagine you're looking at an actual hypodermic needle. Again, they get nervous and tense, and we go through and help them relax. And then when they can get through this level while looking at an actual hypodermic needle while being relaxed, we move up to the next level of the hierarchy. So this is systematic desensitization where we use their thoughts. We're imagining these situations and helping them behaviorally relax their body. Another type of cognitive behavioral therapy is Albert Ellis and his rational emotive behavior therapy. And his idea was that people have these unrealistic beliefs, that they're often perfectionistic in nature, and they think how other people should think and act and how they should think and act, and that leads to disappointment because, of course, nobody is perfect. And so the goal is to help people identify their irrational or illogical thoughts and convert them into rational ones. So instead of saying, I should do this, I should clean the house, I must be, perfect in every way, saying, wait a minute, you can't do that. Nobody can be perfect. And maybe you shouldn't have to clean the house every day. That's okay if it's a little messy one day. And so you focus on changing the thoughts and changing the behaviors. It's often a rather confrontational approach. The therapist is often saying, wait a minute, stop right there. What you're saying is that you should be perfect, and that is not reasonable. You can't be perfect. And so they talk about kind of this alphabetical A, B, C, D, E process of an activating event, some kind of negative situation like the person got fired, and then an irrational belief, the idea that I'll never hold a job again because I got fired, right? And so the consequences of that is they feel hopeless, right? If you believe you're never going to get another job, then of course you'll feel hopeless. And so disputing the flawed beliefs is really important to change the beliefs from unrealistic, irrational ones to realistic ones. Getting fired doesn't mean my career is over. I'm sure I'll get another job. And have this effective new philosophy, right? I can apply for another job. What am I going to do next? And this is sort of the process of this rational emotive behavior therapy. Cognitive therapy, which was developed by Beck. This is a therapy that really is aimed at simply addressing the maladaptive thinking. So that part of the process that is maladaptive in their thinking. And again, the idea that people have automatic thoughts that lie at the root of psychological disturbances, that people have cognitive distortions or cognitive errors that cause them to misinterpret events and then are associated with things like depression and anxiety and aggression and different psychological problems. And that everybody has a cognitive schema that underlies the way we have that underlie our automatic thoughts. Basically, we have a schema, a cognitive schema, a way that we interpret every event, right? It's our perspective. Simple as that. As we're looking at the world and as things are happening around us, we have a way of interpreting these events. That's our cognitive schemas. And our goal of cognitive therapy is to take apart these schemas that are maladaptive and replace them with more positive, realistic thoughts. So this type of therapy really focuses on the thoughts. I have some examples here of these cognitive distortions or cognitive errors that some people have this all or nothing thinking, that things are in black and white, you're either perfect or you're a failure. So if you think like that, well, that could lead to a lot of depression and anxiety because nobody's perfect. And if you're not perfect, then you're a failure, right? That date was a complete failure. Was it really? Was there any parts of the date that were good? Probably. And so you would be questioning the person and trying to get them to have more realistic understanding. Yep, that date wasn't perfect, but it was pretty good. We had a few laughs. We enjoy some of the same things. Maybe it's worth trying again. Even if maybe I spilt my glass of water, it's okay. It was kind of funny now that I think about it. Or the idea of overgeneralization, seeing a single negative event as a never-ending pattern, right? If you think people are having relationship problems, he's never on time. I'm always waiting for him. Well, that's an overgeneralization, likely, if somebody said that to you, right? Has he ever been on time? Probably. And so again, trying to correct this distortion in the thinking. Should statements, someone who is always thinking they should be doing something, that can create a lot of guilt. The house should be clean. I should be cooking a dinner. I should be studying more. I should be nicer to my parents. If there's all this should, that creates a lot of guilt. And personalization, another example, seeing oneself as the cause of a negative event when you were not responsible for it, right? This is all my fault. If I were a better mother, she would have never dropped out of school. Well, is that really true? If your daughter dropped out of school, is it really all your fault? Again, perhaps some of it, right? You can say, well, there might be some of things you could have done differently, but there's also a lot that is on your daughter, who is their own person and making her own decision. And so not to personalize everything. Again, that can lead to guilt and depression and anxiety. And so this is what happens, how we work with someone in cognitive therapy, is looking for those cognitive errors, those cognitive distortions, and trying to make them more realistic. Let's see. Evaluation of behavior therapies, and I'll put cognitive in here as well. They tend to work quickly, both. Aside from the psychoanalytic therapy we talked about, there are some pretty quick cognitive and behavioral therapies that result in not very long in therapy and therefore pretty cost effective, and they have been found to work. We have very good research on cognitive therapies working and behavioral therapies working very effectively for many psychological disorders. However, complex disorders like schizophrenia are not responsive to cognitive or behavioral therapies. How long will the change last, particularly when we're just talking about a behavioral therapy, when you're just doing something like reinforcement in a token economy? Will that behavior continue after the reinforcement ends? There's some questions there. But if you combine the cognitive and behavioral therapy, that's a little bit better because you're also helping to change the person's thoughts. And for plain old behavioral therapy, the observable behavior might downplay some of the social, biological, and cognitive roots. And that's why this cognitive behavioral therapy has become actually quite important and a very useful technique and a very popular one, because it really kind of looks at both changing behaviors but also looking at the thoughts. If you're just looking at cognitive therapy, again, can be short-term and effective for a wide variety of problems. Criticisms are that what's going on here? What happens first? Are people experiencing depression because they have distorted beliefs, or the distorted beliefs causing their depression, or is depression causing their distorted beliefs? It's kind of hard to know. And certainly you can't do cognitive therapy where you're really deeply looking in someone's thoughts with children, let's say, who don't have really the ability to be that insightful. People who are having intellectual impairments of some sort. Not everybody is a candidate for a cognitive type of therapy. Overall, research shows that in general, therapy brings about greater improvement than no treatment. Well, that's good. Going to therapy is better than not doing anything. Spontaneous recovery or recovery without treatment is fairly low. For most people, psychotherapy is effective, but it doesn't work for everyone. Also, there is no single form of therapy that works best for every problem. Certain types of treatment are better for certain types of problems, and not every therapy is appropriate for different people, right? So different people do better with certain types of therapy. Most therapies, however, share several basic similar elements. There's a positive relationship with the therapist. There's an explanation of the client's symptoms. There's some confrontation of negative emotions. There's a place to go and talk about your feelings. And maybe really it's that. It's that is the most important and most healing part of therapy, regardless of if it's a cognitive therapist or a behavioral therapist or a cognitive behavioral therapist, right? That it's just having that place, that positive, supportive place to go that might be the most important. All right, talking about biomedical therapies, we're going to talk about some drugs, electroconvulsive therapy, and surgery. So biomedical therapies, psychotropic medications, those are medications that are generally prescribed by a psychiatrist. And we've talked, I think, in this class about the difference between a psychiatrist who is a doctor who's gone to medical school, and they then can prescribe medications, and a psychologist who has a PhD, who hasn't gone to medical school, but they've spent at least 5 years after college studying how to be a therapist, studying psychological disorders. And so the difference really is this prescriptive privilege, that psychiatrists can write prescriptions. Psychopharmacology, this is the study of how medications alter perceptions, moods, behaviors, and other type of psychological functioning. And we're going to talk about 4 main types of medications: antidepressants, mood stabilizers, antipsychotics, and anti-anxiety drugs. So all drugs work at the synapse, and we have talked about this before, that psychotropic medications change the chemicals in the synapse in some way, and either by releasing more of a neurotransmitter, releasing less of a neurotransmitter, blocking a receptor. In some way, there is something happening in the synapse when someone takes one of these psychotropic medications. So we'll talk about antidepressants first. So these would be medications you take for depression. And they improve mood, primarily used to treat major depressive disorder. Sometimes they're also given to treat anxiety disorders and eating disorders. They sometimes work in those cases as well. There are 3 main classes of antidepressant drugs. We have tricyclic drugs. These increase serotonin and norepinephrine in the synapses. Serotonin seems to be a key neurotransmitter when it comes to depression, that there's not enough serotonin. And so the tricyclic drugs increase serotonin and norepinephrine in the synapses. The issues with the tricyclic drugs is because they're increasing serotonin and norepinephrine, you get lots of side effects. So sometimes people really don't like to take these medications because there are many side effects, because you're really kind of working on 2 different neurotransmitters in the brain. I'm actually going to skip down here to selective serotonin reuptake inhibitors. These are the SSRIs. These were developed after tricyclics, and they increase just serotonin at the synapse, right? It is selective for serotonin. And in this case, these work by being reuptake inhibitors. So if you recall, in the synapse, once serotonin is released, to sort of clear the synapse away, any extra serotonin that hasn't been bound to a receptor goes through this process of reuptake, or almost recycling, and it goes back into the presynaptic neuron. But for these SSRIs, they block the process of reuptake. That's what's happening here. And so the serotonin lasts in the synapse longer. So even though we think people with depression may not have enough serotonin, they release serotonin, and then because that reuptake process is blocked, there is more serotonin available in the synapse to bind to the receptors. And because it's just working on the serotonin system, you have many fewer side effects. So people tend to be able to tolerate these medications much better. This is like Prozac. That was one of the first. If none of those medications work, there's also something called an MAOI, or an MAO inhibitor. This prevents monoamine oxidase, which is an enzyme, from breaking down neurotransmitters. There are also enzymes that are floating around in the synapse, and they break up any extra neurotransmitter, and the monoamine oxidase inhibitors prevent that from happening. So you end up with the same effect, that you have more serotonin in the synapse. The problem with MAOIs, and why they're a last resort, is that there are some serious dietary restrictions because these medications interact with diet. You can't eat foods with like red wine and chocolate and aged cheeses. So there's a number of medication or foods you can't eat, and that is harder for someone to do. So that's kind of a last resort. And we don't know why some of these medications work for some people and not for others. This really is a trial and error process. And hopefully there's a lot of research trying to figure out kind of matching why does some medication work for some people and not for others, so that we could get better at giving someone a medication that we think would be effective right away instead of having to try a number of medications before finding one that works. Mood stabilizers. Mood stabilizers are medications that minimize the lows of depression and the highs of mania. So these are given for individuals who are diagnosed with bipolar disorder. They don't take antidepressants. They take what we call mood stabilizers. You have to really be carefully monitor mood stabilizers. One of them is called lithium, because they have a lot of side effects, and so the person is to be watched pretty closely. But the goal is that, again, you're not, it's not that the person doesn't have emotions. It's that you're just removing the very high highs of mania and the very low lows of depression, and you're just sort of stabilizing the moods, not getting rid of the person's moods. Antipsychotic medications used to treat psychotic symptoms like hallucinations and delusions, so typically for people diagnosed with schizophrenia. And there are two types. We have typical antipsychotics. Those were the first medications, and then atypical antipsychotics. Typical antipsychotics actually both work as dopamine antagonists, meaning we think in schizophrenia there is too much dopamine in the brain, and so by blocking the neurotransmitter receptors for dopamine, even though there's too much dopamine, and I can go back to this picture, they would block these. If these were dopamine receptors, the antipsychotics block these receptors, and so even though there's a lot of dopamine in the synapse, it can't connect with the receptor. It can't activate the receptors. One of the problems is that dopamine is also used in our brain for motor and for movements. And so one of the side effects, a very bad side effect of the typical antipsychotics, is what's called tardive dyskinesia. And this is an involuntary movements where the person has these kind of writhing, twitching, often with their mouth, their face, their hands. They can't stop moving. And the problem is that once it starts, it doesn't go away, even if the person stops taking the medication. And it can be debilitating, that the person has trouble controlling their body, basically, and even eating or drinking, it becomes a big problem in that. As you can imagine, would be a devastating kind of side effect. So the atypical antipsychotics were developed with less of a risk of tardive dyskinesia. The atypical antipsychotics often have another potential side effect called agranulocytosis, and agranulocytosis is a decrease in white blood cells. Now, what happens if your white blood cells decrease? You can't fight off infections, right? And to the point that a person could die. So on those medications, the person needs to get blood tests very often and be sure that their white blood cell count looks good. My daughter had been on a medication, not an antipsychotic medication, but another medication where agranulocytosis was a potential side effect. And so we had to go to the hospital constantly to get blood tests. And if she was ever sick, we had to go straight to the hospital. So it's very a scary side effect for sure. These drugs, these antipsychotic drugs, reduce symptoms, but they don't cure the psychological disorder. So this taking an antipsychotic medication is not going to cure schizophrenia. It's going to be something the person would probably take, probably for the rest of their lives, to control the symptoms. Anti-anxiety drugs, these are medications used for treating the symptoms of anxiety. Most are in the classification of benzodiazepines. This is like Xanax or Ativan. In high doses, these drugs also promote sleep, so they can be used to treat insomnia. How they work is they are GABA agonists. Remember, we said GABA is an inhibitory neurotransmitter. It slows down the functioning of your nervous system, and these medications basically increase the functioning of GABA. So by increasing GABA, you're actually relaxing the person. They're quite fast-acting, but very addictive as well, and can be lethal if mixed with alcohol. So very important to be kind of watching and careful with these types of medications. Research suggests that psychotropic drugs are most effective when used with psychotherapy. So people often can have the choice of doing therapy or medication, but if you can do both, that seems to be the best. And certainly medications affect people in different ways. There are side effects that need to be considered, and so not everybody can take every medication. Sometimes the side effects are just not tolerable, and so we have to discontinue a medication. And depending on if the person is on other medications for other things, you have to be very aware of all of that. Other biomedical therapies, repetitive transcranial magnetic stimulation. These are electromagnetic coils that are put on or above a person's head that direct a brief current into a particular area of the brain. And so this is starting to be a way that perhaps we can treat different psychological disorders basically using a magnetic coil outside of the brain. Or deep brain stimulation, which involves implanting actually a device inside that supplies a weak electrical stimulation to specific areas of the brain. So if there's part of the brain that isn't working as well, then we can use this weak electrical stimulation. Obviously, this is quite an invasive technique in terms of if you were trying therapy to deep brain stimulation, this would be a last case kind of resort. Also, electroconvulsive therapy, or ECT, this is one you may have heard of. This is a biomedical approach that shocks, it's also called shock therapy, you probably heard of that, that uses electric currents to cause seizures in the brain. It has a very bad reputation. It's been portrayed in movies in a terrible way, and it actually did start in a way that was pretty awful in terms of the patient's experience, but it is still used today in hospitals. I've actually seen it done, and it is quite humane and controlled, and it works. And that's kind of the amazing thing. It's a very effective treatment for depression. And again, this would be a last resort option for someone who has very, very severe depression, who has tried every medication and nothing works, who has tried every therapy and nothing works, and they are probably in a hospital, a psychiatric hospital, and they are suicidal. You're afraid that if you let them go home, they're going to commit suicide, and everything else has been tried. Then perhaps ECT would be an option. And when they do this in the hospital, the person is now anesthetized, so you don't feel any pain. The least amount of electrical stimulation is provided to the brain. They're monitoring the brain with an EEG, and just as soon as you start to see a seizure occurring, they don't use any more electricity. It's very safe. If the person, again, is healthy enough for it. Obviously, a person who has heart problems, a pacemaker, something like that, couldn't have this type of treatment. And it works. And I've seen it work where someone who has been so depressed and in the hospital for weeks and weeks, and then they do a session of ECT and they are better. Side effects, confusion and memory loss, although they've, again, gotten better at how ECT is done, and that is usually confined to a very short period of memory loss, maybe for that day. They don't remember kind of what they had for breakfast that day or something like that. It's usually not a huge, memory of their whole life for sure. It's just, at that right around the time of that ECT procedure. Other biomedical therapies, neurosurgery. So this involves destruction of some portion of the brain or connections. We talked about split brain operations, prefrontal lobotomies. Those were done historically for patients who were dealing with schizophrenia. Found not to be a very optimal treatment for that. These are really last resort treatments, would be neurosurgery. And certainly as we go through treatments and therapies, when you're working with a patient, it really is important for a therapist to understand the cultural context in which they're working. When the therapist and client come from different backgrounds, the therapist must be respectful of cultural norms for their client and be cognizant of our own cultural biases. Again, we all come from the world in our own perspective. And as a psychologist, you really have to be very self-aware of being aware of your almost unconscious, subconscious biases and respond to the needs of the person in terms of his or her culture, their religious beliefs, their unique personal qualities. As a therapist, you really can't put your ideas and how you think it should be on your client. You've got to really come at therapy from your patient's perspective, right? Also, group therapy, important to talk about. This was first developed in the 1940s, can be led by 1 to 2 therapists. They can be actual therapists or they can be self-help groups. So there's just a leader of the group who isn't necessarily a therapist. And it can be any type of approach from 3 to 10 participants, although of course that number ranges greatly. And this can be as effective as individual therapy for addressing many problems. It can be the preferred method for addressing people who are having interpersonal problems. Group therapy is a pretty great alternative, particularly for situations where people feel very alone and that they're the only ones who are going through this. So dealing with adolescents, that's a great one. Adolescents often do well in group therapy because they feel like nobody's ever experienced what they're experiencing. They're the only ones. They have it worse than everybody else. And they don't want any advice from adults. So if you have a bunch of adolescents in a group therapy kind of session and the adolescents are giving each other advice or hearing each other's stories, that can be extremely powerful. So group therapy can be a very powerful tool or a very powerful type of therapy. Talked about self-help groups briefly there. They provide support, not therapy, because they're run by maybe a mental health advisor, a paraprofessional, not a therapist, just whoever the group leader is. This can be Alcoholics Anonymous, Parents Without Partners, etc. Again, can be extraordinarily helpful to people, and especially when you're feeling like you're alone, and to hear other people who are experiencing a similar struggle and getting ideas from them can be very powerful. And another type of group therapy would be family therapy, which focuses on the family as a system. And so if somebody in the family is having any kind of issue, let's say we have a family and one of the children is diagnosed with an eating disorder. The idea would be that you can't really treat that child on their own, that that child exists within a family. And there are all sorts of influences on that child from parents and siblings that may have resulted in the eating disorder, at least in part, and that that child is playing a role in the family and exerting influences on the parents and the siblings as well. And so really the only way to help is to focus on the whole family and how the whole family is interacting, that you can't just focus on one person. So it's really to understand each person's role in the family system. Tends to be a briefer type of therapy. So what should you do if you suspect you or someone you care about is suffering from a psychological disorder or needs some support? You should seek professional help. Figure out what kind of therapy fits best for the person and the situation, and then find the right therapist. This is really about fit, and not only is it the type of therapy, which now you know. Most people say if they need therapy, they just pick a name out of the insurance covered names, perhaps. But now you know you can ask, are you a cognitive therapist? Are you a behavioral therapist? Are you a humanistic therapist? You want to see, because maybe one of those types really resonates with you. So that's a question. And then if you want to find a cognitive therapist, let's say, and you do find one, every person is different. And for therapy to be really successful, there has to be a good fit between the patient and the therapist. And so you might go for one session and say, I didn't really like that. Then try to find another therapist. That's really important. And then in terms of financial and insurance information, college students often qualify for free counseling at campus counseling centers, and that's a really good resource to know about. And certainly today there is the emergence of e-therapy. So this would be internet therapy, providing treatment over the internet that can be either just supportive or actual therapy, using email, using webcams and Zoom and things like that. Very valuable service for serving rural areas where there are no psychologists, right? There might be people who live in places where you just can't see a psychologist, and now the world is open to them in terms of being able to see a therapist over the computer, as well as when you are stuck at home or can't get out of your house for whatever the reason. E-therapy can be extremely valuable, but certainly raises privacy concerns because confidentiality is really important with therapy, and so doing things like this over the internet raises a whole bunch of ethical issues that we're all learning to deal with. All right, thank you very much, everybody.